call, including some clinicians, some basic scientists, some trainees. Yeah, Jeff, I think we can probably go ahead and get started shortly here. And again, appreciate you making the time to join us today virtually. As I was saying earlier to Jeff, I know Jeff from multiple collaborations in the mineral metabolism space. Today, he will talk to us about anemia management, but maybe there'll be some crossover into mineral metabolism as well. And Jeff is really truly a giant in nephrology. He's at the forefront of many very impactful innovations in nephrology, and he continues to push the envelope forward. It was a little bit intimidating to come up with the introduction to make sure that I cover all of his many accomplishments, but I will do my best. So currently, Dr. Block is serving as an Associate Chief Medical Officer, Senior Vice President of Clinical Research and Medical Affairs at U.S. Renal Care. But what's exceptional about his career, as I already alluded to, is his impact, but also a very unique trajectory. So before his current role, Dr. Block spent over 2 decades in private practice in Denver nephrology, and he, in that role, cared for patients, but also started a very prolific and a very respected clinical research program that was involved in many seminal clinical trials in the CKD mineral and bone disorder space, cardiovascular risk, and anemia. This work over the years has influenced what's in the guidelines and how we care for patients. One of his very early papers is extremely influential. It was published in JASN, and for many years, if you went to the JASN website, it would be listed on the website as one of the most cited papers. According to my search this morning, it's been cited over 2,700 times, so nearly 3,000 times. And I think it's only second to the citations for GFR formulas. Really kind of amazing accomplishment. And that paper opened the field and led to, ongoing research, both in the basic science space, in clinical research, and certainly impacted how we care for patients on dialysis. Beyond this paper, there have been many other papers, most of which were published in very high impact journals, including New England Journal, JAMA, JASN. And as I alluded to, his work has influenced guidelines, but he has also done important work with formulating guidelines, and he's served on many global advisory boards. After spending this long time in private practice, he then transitioned to leadership roles in industry and large dialysis organizations. So prior to serving at U.S. Renal Care, he served as vice president of nephrology at Rialta Pharmaceuticals, where he helped advance innovative therapies. And now at U.S. Renal Care, he continues to drive research and clinical excellence on a national scale. So today we're very lucky to have Dr. Block speak on innovation in anemia management, and I'm sure you will be able to tell from his presentation how he marries his commitment to bridging science and clinical care. So Jeff, thank you very much. I look forward to
Oh
your
my
talk.
gosh, Tamara, what a wonderful introduction. Thank you so much. And thank you for inviting me to present. And I've known Tamara now for several decades, and I've had the privilege of learning from her over those many years. So what I'm going to share with you for the next 35 minutes or so is our synthesis of the data regarding HIF-PHIs. And I've entitled the talk Innovation in Anemia Management because we spend a lot of time in our industry talking about or using the word innovation or describing something as innovative. And I thought it's worth taking just a few seconds and looking at what that actually means. So when you think about innovation from a definition perspective, it's a process of implementing either a new idea or a new method that results in some improvement or some added value, right? And at U.S. Renal Care, we are profoundly committed to really challenging ourselves to look at all aspects of things that are innovative or might be innovative in the way that we deliver care. We very much believe that we cannot be satisfied with the care we deliver today. We can deliver better care, and we can deliver better outcomes for our patients with kidney disease. So I'm going to share with you, I absolutely believe that what I'll share with you about vadadustat and HIF-PHIs in general absolutely represents real innovation in the field of anemia management. And I challenge everyone, and I'm actually was happy to hear there are some fellows in the audience, challenge everyone to, as they listen to this presentation, as always with my talks, I don't expect everyone to agree with me, all right? I hope you think about what your own practice is. All of us are comfortable with the way we've been doing things for the last 30 or 40 years in anemia management. We've had subtle variations over since 1989 and the introduction of EPO and how we manage anemia, but frankly, very little real innovation. All right. So I challenge you that even though you're comfortable knowing how to do that, think about the things that I'll present to you today and ask yourself whether or not we can be better than the way we were or where we are today. So why vadadustat? To me, in our organization, this is the most important question, right? If we can help clinicians and providers and our staff and our patients understand why we believe vadadustat represents an opportunity, then that's 75% of the battle, all right? So I'm going to focus this presentation on why we believe vadadustat is an important and innovative therapy in the field of anemia management. And I'm going to do it using this concept of three pillars. All right. We have three pillars that we rest our belief on, and I'm going to share those with you in some detail. The first pillar has to do with the mechanism of action of vadadustat, right? And the fact that it targets what is an incredibly unique cardiovascular risk profile for people on dialysis, and in particular, people on hemodialysis. And it's a mechanism of action and a targeted approach that is completely distinct from ESA. All right. So while they both manage anemia, they are incredibly different from each other with regard to how they achieve that outcome. All right. And so the mechanism by which VADA works has to do with the response to tissue hypoxia. All right. It's a response to cellular hypoxia, tissue ischemia, whatever word you want to use, but reduce oxygen delivery to a tissue. And I want everyone to really think about, in particular, when we talk about hemodialysis, all right, we all have to acknowledge that the procedure itself exacerbates and contributes to tissue ischemia, organ ischemia, almost every single time we deliver this therapy. All right. And Chris McIntyre has really done, I think, profoundly important work over the course of now 15 or 18 years. And I listed there several reviews that he's recently published on hemodialysis-induced organ ischemia, and in particular, his work on cognitive decline. And I encourage you to take a look at. But the very short summary of this elegant body of work is that hemodialysis causes organ ischemia that affects long-term organ function. So we know that our patients ultimately die of a heart failure death, and that's from repetitive injury, repetitive myocardial stunning that happens during dialysis. They have progressive decline in cognitive function, which is honestly just appalling, right? When you go back and you look at some recent work, for example, in the HDF clinical trials, and you look at comparisons of HDF versus high flux, and you look at cognitive decline, what's striking is not whether one therapy is better than the other. What's striking is that everybody gets worse in their cognitive function over the course of time. And this is a result of repetitive organ injury induced by the procedure. All right. So we have to acknowledge that what we're doing for our patients induces this problem of tissue hypoxia or organ ischemia, all right? And that is exactly the pathway that HIF-PHIs exert their mechanism of action, all right? Hypoxia inducible factor is in fact the master regulator of the response to tissue hypoxia, all right? And I'm not going to go in great detail about how they work, but there are some aspects you need to be aware of, all right? The most important, fundamentally important part of this is that essentially every cell is making HIF alpha all the time, all right? The precise cellular distribution of which HIF alpha they're making is slightly different and really not that important. But every single cell is making HIF alpha all the time. It's constitutively expressed. But because we don't need to actually stabilize this pathway all the time, we have a system in place that simultaneously breaks that down as long as there's enough oxygen. All right. So HIF alpha is acted upon by what you see here, this prolohydroxylase domain enzyme. All right. And as long as there's enough oxygen and a few other cofactors like iron, all right, that PhD hydroxylates HIF alpha on several proline residues, which targets it for attachment to the von Hippel-Lindau complex, ubiquitination, and degradation in the proteasome. So we waste a lot of energy in every single cell by making HIF alpha all the time and breaking it down all the time as long as there's enough oxygen. And the reason we do this is because we need to be able to instantly respond if there's not enough oxygen. And the way we do this is through that PhD. If there's not enough oxygen delivery to that cell, all right, then PhD becomes inactive. That HIF alpha is free to move into the nucleus where it interacts with HIF beta. And again, along with several other cofactors, turns on a large number of things that help that cell survive, respond to, and adapt to hypoxia. And those things include erythropoiesis, they include iron homeostasis, but they also include other things that are not what in your pathway of sort of standard anemia sort of conceptual framework. And that includes inflammatory response, oxidative stress response, endothelial health response, and importantly, energy metabolism, right? So stabilizing HIF is meant to help that cell respond in an overarching manner to hypoxia. All right. Now it's not, I just point out that it's not the only thing that regulates this pathway, but it's the predominant thing that regulates this pathway. All right. And the way vadadustat works is by temporarily blocking PhD. It temporarily stabilizes HIF, and it allows those series of downstream effects to take place transiently. All right. And it's important, why I bolded and capitalized these words, is these drugs do not permanently activate or stabilize HIF. All right. They temporarily and transiently block PhD, which allows for a short-term response downstream of HIF stabilization. All right. And that's a really important aspect of what happens with these medicines. Now, I just want to make one other comment about the ubiquitous nature of what HIF stabilization does as it relates to anemia. All right. So, unlike EPO, HIF stabilization affects all aspects of erythropoiesis. And importantly, as described on this slide, when you stabilize HIF, several of the early response genes are depicted here. You have an increase in EPO concentration that I'll talk about in just a minute, all right? That happens very quickly. But you also have an increase in transferrin receptor expression on the bone marrow erythroblasts. You have an increase in the expression of duodenal transporters, which absorb iron and help move iron across the intestinal epithelia and out into the bloodstream, all right? So you increase intestinal epithelial transporter expression, you increase ferroportin expression, you increase transferrin expression, all right? And you increase essentially everything that needs to happen to both absorb oral iron and utilize stored iron and transfer that stored and absorbed iron to the bone marrow so it can be incorporated into erythroblasts at the right time, all right? So all of that is distinct from what happens when you give somebody EPO or ESA to manage anemia, all right? Now, the other thing that I think most of you are probably familiar with now is that this coordinated erythropoietic response activates another hormone called erythropoietin. Erythropoietin is what goes to the liver and helps suppress hepcidin. All right. So you have this combination of effects where HIF stabilization increases oral iron absorption, increases iron transport, increases iron utilization, and reduces hepcidin, which is suppressing all of those things simultaneously. So this is a really unique aspect of what we accomplish with HIF stabilization that we don't accomplish today with ESA. And I got to tell you, one of the things that frustrates me the most when I'm talking to folks about managing anemia with HIF-PHI versus EPO is when people say to me, they do the same thing. All right? All right? Saying these two classes of drugs do the same thing is as stupid as what I have on this slide. Okay? These are not all the same thing. All right? These are distinctly different from each other. All right? So while the end result, one of the end results of HIF-PHI and ESA is making hemoglobin go up, they couldn't be more different from each other. And I would challenge all of us to stop thinking about, are we managing hemoglobin? All right. And when we think about managing anemia in ESKD in particular, think about, are we managing cardiovascular risk? All right. So ESA achieves a very specific goal, which is a hemoglobin. It has a very, very narrow therapeutic window. All right. All of you know that. Both the hemoglobin has a narrow window and the ESA has a narrow window. All right. And above that window, you have clear evidence of harm. All right. HIF-PHIs work completely distinctly. They promote the cellular adaptation to reduce oxygen delivery, which we are causing when we dialyze patients. All right. And they help correct the reduced oxygen delivery by mimicking all aspects of the physiologic coordinated erythropoietic response. All right. So that's the first pillar. Very unique action, very targeted potential benefit for people who are exposed to repetitive ischemic injury over and over again. All right, the second pillar that underscores our foundation is the observational data that really strongly suggests that HIF stabilization in dialysis patients is associated with improved clinical outcomes, all right, and reduced mortality. And I'm going to show you why the observational data that I'm referencing, and it starts with understanding or thinking about a little bit what happens in the normal response to hypoxia, all right? And if you see on the left-hand side here, these are the things, this comes from a New England Journal of Paper review a few years ago, which is really excellent, all right? If you look at the normal response to hypoxia, all right, what you see is it happens, first off, immediately, and now we know why. We know how we can respond so quickly, and it's through this HIF pathway. But what happens is immediately your ventilatory rate goes up, your heart rate goes up, your PA pressure starts to go up. But within minutes, all right, within minutes, your EPO concentration goes up. It goes up a little bit, and then it comes back down to normal. Within days, it's back down to where it was before the hypoxic event, all right? And that short, small increase in EPO concentration is enough to stimulate hemoglobin, red blood cell production, okay? And we see increase in hemoglobin. So when you all come to Denver where I live, you get off the plane, you're at altitude, PO2 goes down. What you see on the left-hand side happens immediately because of HIF, all right? And you compare that on the right-hand side, what I'm showing you is what we do today with EPO when we use it, regardless of whether you use a standard EPO or Aranesp or pegylated EPO. What you see are these incredibly high concentrations immediately of EPO, right? Which drop immediately. So there's always this seesaw pattern, depending on the kind you're using, but there's always a seesaw pattern that goes from very high to essentially very low with EPO concentration. And that is completely different than what happens in the normal physiologic response. All right. And I hope that all of you are well aware that that pattern or dosing strategy of EPO, many of us believe may be contributing to what I'm showing you on this slide, which is this very consistent evidence that when you look at the relationship between EPO concentration and outcomes in people on dialysis, what you see is a very steep curve that shows that the more EPO a dialysis patient gets, the more likely they are to die. And yes, we all know this is confounded by people who require EPO, and I'll assure you that this analysis that I'm showing you is as sophisticated analysis as can be done to account for that confounding. All right. And I think what many people really don't stop and think about is the level at which this risk starts. All right. So if you look, I don't know, can you see my pointer here if I move my pointer? Yeah, okay, good. So if you look here, this is a very large number of both incident and prevalent dialysis patients, more than 100,000 prevalent patients, and I think 50,000 incident patients. And you look at this is 18,000 units per week, all right? That's 6,000 units per treatment for a 3 time per week hemodialysis patient. So when you go at 6,000 units of EPO per treatment, you have, nearly a 20% increase in the risk of death. All right. When you go to 10,000 units of EPO per treatment, you're talking about a fully adjusted, multivariable adjusted, time-dependent adjusted 50% increase in the risk of death. All right. So the more EPO we give to our patients, the more likely they are to die. All right. So now that we have an alternative, right, we really have to ask ourselves, right, are we doing everything that we can do to reduce that risk that I just shared with you? All right. And I want to frame that again in thinking about what we're doing with regard to physiologic adaptation to ischemia or hypoxia, what we do with EPO on the far right, and what we do with HIF-PHI on the far left. And if this just looks at EPO concentration, and what you can see is that when we physiologically adapt to hypoxia or ischemia, again, you see this little tiny increase in EPO concentration. You compare that to standard dosing of EPO, which goes from 50 to 100 units per kilo 3 times per week, and you can see you get a massive increase in EPO concentration, right? The data with HIF-PHI, and this is data from roxadustat, but it's similar to data with all of the dustats, all right? The concentrations that we see that are effective in raising hemoglobin cause tiny, tiny increases in EPO, all right? So we know, and I'll share with you, we know this is effective to raise hemoglobin, right? We know this is effective to raise hemoglobin, but this is what we're doing over here, all right? So again, I'll remind you that the best example in nature of this middle physiologic adaptation is altitude. All right. All right. So this happens at altitude. So let's ask ourselves, what's happening to dialysis patients and their care they're getting and what they need at altitude? And let's compare what happens to a group of dialysis patients who live at sea level versus a group of dialysis patients who live at altitude, everything else being the same dialyzers, same equipment, same hemoglobin targets, everything else is the same, all right? Characteristics. Let's look. What you see is that at altitude, people are far less likely to require EPO, all right? When they do get EPO, their dose is far less, significantly less. They are less likely to require iron, and their hemoglobins are better. So we accomplish what we want to accomplish with using less medicine and conferring less risk as a result. All right. So you would think that this relationship at altitude would translate to risk, and in fact, it does. All right. When you look at one of the best predictors of cardiovascular risk with ESAs, and you think about the group that is hyporesponsive, living at altitude reduces the likelihood of ESA hyporesponsiveness by 50%. All right. And importantly, in their analysis, dialysis patients at altitude had a 27% reduction in the risk of death. All right. So there's no other realistic explanation for this other than HIF stabilization occurring at altitude in a group of patients who are uniquely at risk for repetitive ischemic injury. So I think this is pillar 2 for us. The observational data support what we think should happen based on mechanism of action. All right. Now, the third pillar let's talk about, and this is where I'll spend most of my time, is what do we know from clinical trial data? So we have basic science data, we have observational data, and what do we know from the actual randomized clinical trial data? Well, I'll suggest to you that our synthesis of this is that these demonstrate a consistent signal of a reduction in the risk of MACE events and cardiovascular events, all right, with that. And let me walk you through that. I happened, as Tamara said, over the course of my career, I've been really privileged. And one of the things I had the ability to do was be on the steering committee for the global development of vadadustat. And I was one of the members that helped analyze and publish the data with vadadustat that we published a few years ago in New England Journal. All right. So I've been thinking about this and using these medicines for quite a long time. I'm not going to spend a lot of time on this. I think you all are familiar. The global design of these studies was very straightforward. We randomized people 1-to-1 to either receive daily vadadustat or darbepoetin. These are dialysis patients. We followed them for approximately 3 years. There are two endpoints. The efficacy endpoint was a hemoglobin endpoint between weeks 24 and 36 or weeks 40 and 52. And then the safety endpoints were MACE events over the course of the trial. All right. And that's where I want to focus on more than anything. What do we know about safety? So a priori, the primary safety endpoint was MACE, which is heart attack, death, and stroke, right? And these trials were designed as non-inferiority trials to show that VADA was non-inferior to darbepoetin with regard to MACE events and in efficacy hemoglobin, all right, maintenance. And I just want to just comment on this. In order to interpret non-inferiority, you have to realize that the FDA and the EMA established this threshold of 1.25 in the US or 1.3 outside of the US, all right, such that the upper bound of the 95% confidence interval had to be below that threshold in order to say that the VADA was non-inferior to darbepoetin, all right? And I want to talk about that for 1 second because that actually can be a fairly confusing design, all right? And there was an excellent review published in the New England Journal of Medicine, and I took this image from it because I think it's worth walking through how do you interpret a non-inferiority design. So in this example, they used a margin of 1.2. Remember, I told you in the VADA trials that was 1.25 or 1.3. But the important thing is look at where the hazard ratio is 1. The circle represents the actual hazard ratio, and the two ends represent the confidence interval around that estimate. All right. So in this design, something can be non-inferior and superior if both confidence intervals are to the left of 1. It can be non-inferior as long as the upper bound is below this margin, right? And the lower bound is on the other side of 1. So that's just pure non-inferior, all right? Confusingly, it can be non-inferior and inferior, all right? Your hazard ratio is worse and both of your bounds are on the right-hand side of 1, but the upper bound doesn't cross the threshold, all right? So this can be non-inferior and inferior, all right? It can be inconclusive where they go all over the place, all right? And then it can be truly inferior where you have hazard ratios on the right-hand side of 1 and both confidence intervals and the upper bound goes above. So keep that in mind, all right? This is important. Now, people push back on this VADA data because they're like, oh, they didn't show superiority, right? Well, they didn't try to show superiority, all right? They tried to demonstrate non-inferiority. And I'll just remind you, importantly, that the only other outcome trial of ESAs used an identical design. This was published looking at the safety and efficacy of Mircera versus conventional ESAs. It's nearly identical in its design. It's about 3,000 patients followed for 3.5 years. They also had a primary endpoint of MACE in a non-inferiority design. And I just want to point out to you that in this very large study of Mircera versus conventional ESA, the MACE event rates are essentially absolutely identical, okay? Down to the 10th decimal place, essentially identical, all right? And same thing with mortality. I mean, it's remarkable, frankly. There's no question that from a mortality perspective, these drugs were identical, all right? Now I want to show you what we saw with the VADA phase 3 trials, right? First, let me just point this is my own perspective here. We are not comparing apples to apples when we actually use this design where we enroll patients and we randomize them to VADA or Darby, okay? Because in order to get into this trial, what I want to highlight here, in order to get into this trial, everyone had to survive EPO, all right? And they had to survive dialysis. They had to survive the ischemia we cause, right? So these people have been on dialysis for 4 years. So what we did is we took people who survived the comparator drug exposure and then randomized them to compare VADA versus ESA. So it's not apples to apples what would happen if you took brand new patients who had never been exposed to either drug, right? From an efficacy perspective, I am keeping an eye on time, Tamara, and I will end on time, I promise. I'm honestly not going to spend too much time on efficacy, all right? Because I can assure you that this class of drugs has been studied now in 18 phase 3 global randomized controlled trials, and they work, okay? In every study, they work to achieve and maintain hemoglobin, right, in the target range, all right? And they do it with that small increase in EPO that I mentioned. With that in particular, we almost always see this very early dip in hemoglobin for about the first 3 to 4 months. After 16 weeks, it becomes identical to Aranesp, and it stays there for the next 2.5 years. All right. So, and we knew when we were doing this trial, we would find this. All right. Let me just tell you, the steering committee knew this would happen because what we did is we took everybody who was on EPO and we randomized them either stay on the dose of EPO that was working or we moved everybody to the same starting dose of VADA. And of course, the same starting dose doesn't work for everybody, right? And so we knew that we were under treating a number of people. That's just the way we had to do it. So we knew this would happen, all right? But it works in both the primary efficacy period and secondary efficacy period. The drug maintains hemoglobin in our target range and stays and keeps it there, all right? Now, what about safety, which is the big deal, all right? These are the primary and secondary safety things in the phase 3 trial. So the hazard ratio showed a 4% reduction in MACE events. Again, the hazard is to the left of 1. Both the confidence intervals cross 1.0, but the upper bound is clearly below the non-inferiority margin of 1.25. So it was no question the drug was non-inferior to Darby with regard to MACE, all right? When you look at all of these key secondary safety endpoints, expanded MACE, cardiovascular death, or all-cause death, all of them show a 4 to 5% reduction in the hazard ratio with VADA compared to Darby, although none of them are statistically on both bounds on the left-hand side, all right? So, but a consistent 4 to 5% reduction, all of which were non-inferior to Darby-Puig, all right? When you look at the black box warning events, and I hope particularly, again, the fellows on this call know, every ESA has a black box warning, so does VADA, all right? The black box warning events, so when we look at safety events, we don't do statistical comparisons generally, right? So these are not hazard ratios and confidence intervals. These are rates of events. All-cause mortality, the rate was 9.0 with VADA, 9.6 with Darby. MI, a little bit lower with VADA. Stroke, a little bit lower with VADA. DVT, a little bit lower with VADA, all right? The only one that's even the same is the cumulative vascular access thrombosis, all right? PE, a little bit lower. Bottom line is the black box warning events were all either the same or a little bit lower with VADA than they were with ESA, all right? And then the other thing that we think is important is now accumulating evidence of the consistency of the signal that we see. Because you probably know daprodustat was approved by the FDA. Daprodustat studied about 3,000 patients. Vadadustat studied about 4,000 patients. And what I've shared with you on this slide is sort of a very, very brief summary of what they show with safety, right? Dapro had a 7% reduction in the risk of MACE. VADA had a 4% reduction in the risk of MACE. I won't read all of these for you, but 4% risk reduction in all-cause mortality, 5% risk reduction in all-cause mortality, all right? So now we're talking about 7,000 dialysis patients followed rigorously over time, and every one of these shows these signals are in the same direction, which is reduced cardiovascular events with a drug that we believe probably should cause reduced cardiovascular events in our patients. And then finally, I just want to share with you one last thing about that I really like that was presented in this year's ASN, which is a different way to look at outcomes rather than just, MACE or death or hospitalization separately. This concept of a win ratio or win odds ratio, where we can use all of the meaningful events, right? And so the investigators went back to the vadadustat trial, and the way you do this is you take essentially every VADA patient, all right, and you match them to every Darby patient. So you create hundreds of thousands of pairs of comparisons, all right? So every VADA patient with every Darby patient, and then you compare that pair on a hierarchy of outcomes. The most important is death, right? So you compare them on death first, and you see who won, who lost, and whether if they tied, right? If they tied, then you look at hospitalization and you do the same thing. Did they win? Did they lose? Did they tie? All right. And if you do this, then you can get what's called an odds ratio. All right. And it's a little unfortunate they reported an inverted odds ratio, which was it's a little confusing, which is how likely was VADA to lose. Okay. Um, um, but nonetheless, when you use this and you look at the phase 3 trial, what they showed is if you look at this outcome in the trial, while patients were on study, whether they were getting VADA or not, all right, they showed a significant, people getting VADA were significantly less likely to lose in this outcome, right? And if you look at while they were actually taking the drug, plus another 28 days, right, they showed a 15% less likely to lose, meaning more likely to win, all right? So again, it's consistent with the data that I just shared with you about how we think about meaningful events when we think about anemia management. And I'll remind all of you, because you may not know this, but VAD is new to the US last year, but it's been approved in 37 countries. It's been used in Japan now for 5 years, more than 5 years. It's been approved in Europe for some time. And over 5 years, there's no skeleton in the closet that's come up with regard to unforeseen safety signals that weren't observed during the course of clinical trials, right? So let me move on now and talk about how we use VADA. Okay, so the why we use VADA are those three pillars, and how we use it, I think, is important because there are some aspects of how we use it that are relevant to our practice. All right, and there are undoubtedly challenges with daily VADA. Okay, I get a little tired of hearing it, but because I get blasted with this in the phosphate world, right? But there are challenges with adherence, okay? People call it non-compliance, whatever you want to call it, but taking a drug every single day is tough for all of us, right? So there are challenges. When you have a drug like this, you have to prescribe it. It has to go to a pharmacy. It has to be shipped to a patient. They have to get it. They have to pick it up, okay? That represents some barriers and some hurdles that are actually quite complicated. If you want to change the dose, then you have to write a new prescription a lot of the time, which means you have to go through that whole process again, and then you have to make sure the patient's actually taking the right dose at home. And that creates this gap in time between when you want to change something and when the change actually happens. And that gap can be 2 weeks during which hemoglobin continues to change. And so it gets difficult, all right? And most importantly, it's a different process than managing ESA in the clinic, right? Or managing ESA at home. So there are all these challenges. And so we know that if we could, for our in-center patients, align vadadustat administration with a 3-time-per-week schedule, this would overcome many of the challenges with implementing VADA in the treatment paradigm. Now, what I think most people don't know is that there have been a very well done study looking at 3-time-per-week administration of VADA to dialysis patients. All right, that's called FOCUS, and I'm going to share with you those results. That was published last year or the year, slightly maybe the year before, right? Actually, last year. We are doing, and we have now been doing for 15 months a randomized controlled trial in 2,000 patients looking at outcomes, meaningful outcomes using vadadustat 3 times per week. And I'll share with you one bit from that. For those of you who like the summary and go back to doing something else, here's the summary of the FOCUS trial, all right? It's a 450 patient, 1 year randomized controlled trial with 3 times per week EPO. It showed equivalent hemoglobin control and a very favorable safety profile, all right? And importantly, the reason it's not on the label to give 3 times per week is because the FDA didn't review this study. It wasn't in the package of information shared with the FDA at the time of review. So but it has been studied, and this is definitely big enough, long enough, good enough to be reviewed. The design of that study, I'm just very briefly going to share with you so I can have time for some questions. Very straightforward. People were randomized to either get 600 3 times per week, 900 3 times per week, or stay on Mircera. It was a 1 year study. It had hemoglobin as its endpoint, all right? And at the end of the day, this is what the hemoglobin looked like. Again, very short, small dip in hemoglobin when you start, a little bit less than when you use daily, right? Because we're using higher doses. But you can see that the VADA arm stayed on average stable over the course of 1 year. The Mircera arm actually went up a little bit, but they were not different from each other. And they were in target range. So it works. From a safety perspective, this is what I want to point out. This should be my fourth pillar. I just want to share with you the safety. Remember, safety here is not a statistical finding. These are rates again, right? These are the rates of the cardiovascular events in this 3 times per week versus Mircera, all right? And I'll just share with you, when you look at what turns out to be the right starting dose, which is 900 milligrams 3 times per week. Again, this is for in-center patients. The MACE rate was 12.4 with VADA and 17.2 with Mircera. Mortality was 9.3 with VADA, 12.2 with Mircera. All right. If you look at MACE plus serious heart failure, it's lower with VADA than it is with Mircera. If you look at MACE plus serious thromboembolic event, it's lower with VADA. All right. My point here is obvious. All of these cardiovascular safety events rates are lower with 3 times per week VADA than they were with numerically lower than they were with than they were with Mircera. Now, I can't share with you results from our voice study, but I'll tell you that first off, I'm proud as heck of what we're doing. We recognized that 3 times per week was the right future for this drug, and we wanted to study it rigorously. So at USRC and Satellite, we have randomized. We went to the FDA, we wrote a protocol, we submitted an IND, we are the IND holder. We randomized 2,000 patients to either get standard of care ESA 3 times per week or VADA 3 times per week, all right? It's an 18-month trial with the primary endpoint of this win-odds ratio incorporating all-cause mortality and all-cause hospitalization, all right? And again, I can't share with you the results yet because I don't know them. We've been doing it for 14 months. I can share with you a hemoglobin result, right? This represents, as you see, at the moment we made this slide, we had 500 or 600 patients out 4 months, 300 patients out 6 months. And I can tell you that hemoglobins, as you would expect, essentially are equivalent in the two treatment arms over the course of time. All right. So we'll have our results at the end of this year with this trial, but we are really pleased with the obvious efficacy from a hemoglobin perspective. I'll share with you that it's important that you realize that you dose this medicine differently, whether you're using it daily or using it 3 times per week, all right? When you use daily for your home patients, for example, right? For your home patients who are perfect candidates for this, all right? The dosing goes from 150 milligrams up to 600. So the starting dose is 300, and there's only 4 dose steps total. You can go down 1 dose step or you can go up 2 dose steps, all right? When you use it 3 times per week, there are similarly only 4 dose steps, but you start most people at 900 milligrams. You can only go up 1, and that's to 1,200 3 times per week, and you can go down 2. All right. So we we've learned a lot. Let me just tell you, we have learned a lot about dosing vadadustat, right? 3 times per week, right? And I can tell you that sort of without any doubt, 70 or 80% of people can successfully convert from ESA to TIW VADA without need for any ESA, all right? Um, and we now know that. There are some issues when you use TIW, because you're using higher doses, we do run into some tolerability. Some patients who don't tolerate those higher doses initially quite as well. All right. It's definitely dose related. It gets better over time. All right. Reassurance helps, right? Because one of the side effects with GI tolerance is it can cause some loose stools. So you want to think about making sure people aren't taking laxatives at the same time. All right. And if you need to, you can reduce the dose down to a tolerable dose and then follow hemoglobin and go up. All right. And when we think about what constitutes not responding or an inadequate hemoglobin response, all right, we define that at USRC. We've chosen to sort of define that as a hemoglobin less than 9.5 at the most VADA you can tolerate. Okay. All right. And you have some choices when you find yourself in that situation. All right. First off, we remind everybody to look at what they're doing with iron. Make sure you've actually titrated the dose of VADA before you label someone. Remember, there's a dip, which is expected. So if you don't do anything in that period of time, then hemoglobin will likely not go to your desired level. All right. So you make sure you titrate it, make sure your iron management is in line with sort of proactive iron repletion, right? And then you have some choices. You can temporarily choose to use EPO and resume VADA when hemoglobin comes up. Or many of our doctors, honestly, many of our clinicians are choosing to use simultaneous low dose EPO and maintain a lower dose VADA. All right. That requires a physician order, right? Many of our docs are choosing to do that. And I want to just tell you, I don't have a slide on it, but we're actually going to be starting a study, a formal study, looking at a better way to transition folks that incorporates titrating down EPO while you titrate up VADA. All right. Um, so just think about what you've done and what you can do when somebody transitions to TIW VADA and their hemoglobin isn't what you're trying to accomplish. All right. You don't have to permanently stop VADA and you don't have to permanently go back to ESA. Right. Um, and I can tell you, we have made the decision, Dr. Pasquale and myself and the other members of the medical office have made the decision that we believe the data strongly suggests a benefit with not just with VADA, but with TIW VADA, right? It is now our preferred dosing strategy for in-center hemodialysis patients. And I'll just share with you, I know you have both in-center and home, so some of this applies to in-center. But what we're doing at USRC is we're relooking at every eligible patient for consideration of vadadustat for the reasons that I went through initially. I want to tell you one of the biggest barriers are doctors, all right? Um, Doctors who are reluctant to change their practice pattern, doctors who are reluctant to do something that causes a little more work for themselves, all right, or requires a little more explanation for patients as to why we're doing this, all right? And overcoming doctor reluctance is challenging. So about 9,000 of our potentially eligible patients, the doctors just said, I don't think my patients are going to be adherent to a daily oral med. So TIW overcomes that particular physician barrier. All right. So we're asking our docs to think differently if we're moving to TIW. We also want them to think about people who might not have been successful with daily. Maybe they weren't able to take it on a regular basis. Maybe they didn't pick up their prescriptions on time, and maybe TIW will overcome that barrier. All right. So we have a couple thousand people who we think might benefit in that category. And then finally, as I said, we're becoming more and more comfortable accumulating evidence, and we're going to be synthesizing this shortly, of people who are choosing to use low dose intermittent EPO, should say low dose or intermittent EPO, while they use vadadustat, all right? Particularly for those who are EPO hyporesponsive. So this I hope I've tried to summarize for you why we feel the way we do about data, where we think we can move not just USRC and satellite, but I hope the whole country to a really embracing an innovative anemia management that does more than just treat EPO, more than just treat hemoglobin, and look at cardiovascular risk. And I'm happy, and I hope we have enough time. I think we have time for questions, Tamara.
Yes, yes, we do. Thank you very much, Jeff. I think if people can raise their hand, it looks like we have our first question from Dan. Go ahead, Dan. Dan, can you unmute yourself and ask your question?
I was saying, thank you for a nice presentation. Can you expand on the issue of evidence that during hemodialysis there is indeed hypoxia? Is it tissue hypoxia? How is it assessed or quantified? Is just plain systemic hypoxemia? And how does it compare to, say, peritoneal dialysis, which theoretically there should be less of that, if I understand the concept?
I'm gonna need someone to help me. I understood. I not understood. I heard about half of it because my volume is it was very low for me.
Yeah, I think he wants to know what is the evidence for hypoxia induced by hemodialysis, and how does that compare to peritoneal dialysis, for example?
Yeah, you bet, of course. So the
Thank you.
best evidence in hemodialysis-induced organ ischemia is the work of Chris McIntyre, who has looked at this in a number of ways. The most impressive ways is that he is able to do real-time ultrasound imaging of myocardial function during dialysis, right? And he can quantify myocardial shortening in particular segments, and he can add up how many segments actually get stunned during a dialysis procedure, right? He's done this, interestingly, not just in adults who have underlying coronary disease and other vascular issues, right? Where he has shown really clearly in adults that myocardial stunning, this sub-lethal and doesn't kill cells, but it causes repetitive injury to cells, results in long-term reduction in myocardial function. And you can quantify the number of wall segments that get affected, and it's clearly related to ultrafiltration, right? The more you ultrafilter, and it starts happening at low levels of ultrafiltration, but the higher the ultrafiltration and the bigger the drop in blood pressure, the more segments that get stunned. But he's also shown it in kids, Daniel, which is so interesting, right? Who do not have underlying coronary disease, who do not have the issues that adults have. And he shows the exact same findings that kids undergo myocardial stunning during dialysis, the same way that adults do, and it's related to the same factors. He's also done this with PET scanning during dialysis, looking at cerebral blood flow, right? And he can show really clearly reductions in cerebral blood flow, which he then can correlate to long-term cognitive decline in our patients, right? So honestly, it's really clear that we cause this ischemic injury. Now, the paper that I put on that slide about tissue hypoxia was different. There, they actually took a large group of dialysis patients and they measured O2 sats during the dialysis procedure, right, on everybody, right? And they demonstrated that about 10% of dialysis treatments, I think it was treatments, not patients, had then they set a very large threshold, honestly, a high bar for what they determined was tissue hypoxia, and about 10%, which I think their number was something a continuous O2 sat less than 80% or less than 85%, like really clearly hypoxic. So that particular study was a little different, but it's obviously related to Chris's other work. So I think there's no question that our patients suffer from tissue hypoxia and organ stunning, certainly with hemodialysis. The evidence for PD, we don't have that same evidence for PD, right? I think most of us believe PD represents a real opportunity to reduce that repetitive injury, reduce that burden. Now I should tell you, I didn't show you the data on VADA and PD. The results look qualitatively identical, all right? Quantitatively, they only had a small number of PD patients, right? So the hazard ratios are similar, but the confidence intervals are much wider with the PD population. So I can't share with you the same level of confidence in cardiovascular risk reduction with PD, but qualitatively it's the same.
That's
Thank you
great.
very much.
Penelope.
I would like
Oh,
to
go
just
ahead.
add to that.
Yeah,
You know,
sure.
I'm no expert in this, but I have read that there's a particular situation called sort of pseudo-hypoxia, which occurs in PD, and that's sort of stemming from the high dialysate glucose that leads to this pseudo-hypoxia and altered metabolism, triggering progressive fibrosis and thickening of the peritoneal membrane. And that may be also linked to activating factors such as this HIF. So that's in some of the basic science articles that I've read of the impact on PD.
Thank you, Taylor.
It's great. Penelope, do you want to ask your question?
Yes, thank you. Thank you for the wonderful talk, Dr. Block. Really appreciate all the insights from the clinical trials. And I agree that with the PHT inhibitors, we have these lower active ESA concentrations as opposed to the intermittent injections, and this is a big advantage. But in terms of now the therapeutic window, there is the HIF activation. The current compounds are non-specific for different PHT isoforms. I mean, definitely it's good to see the data from these trials on 3,000 patients and all that, having, non-inferior outcomes. But do you think that right now, with the approvals in place, that we should start focusing on certain populations that could be at risk for adverse effects, in terms of renal cell cancer progression, diabetic retinopathy, to patients with pulmonary hypertension? Should we basically see, do we need data, longer observation data? And then in terms of potential advantages, do you think that there is an opportunity in terms of understanding more iron utilization and how, the iron needs are basically, changing in these patients on the PHIs?
Yeah, thanks, Penelope. Those are some good questions. So let me share my perspective. I think that broadly, I believe VADA is an appropriate first-line consideration for everybody, right? Let me just say that. I think there are some groups that warrant some consideration on either side, either uniquely beneficial, right, or potentially you might not want to use vadadustat, all right? On the potential beneficial side, I think it's really clear that people who are ESA hyporesponsive and are receiving very large doses of EPO, right, are a group that are at very high risk, and might uniquely warrant considering VADA clearly as first line. All right. By the way, I think you said hypertension. Let me just say that the risk of hypertension, in fact, was identical in the two
Pulmonary
in the two arms.
hypertension.
And in fact, worse severe hypertension, better with VADA, right?
Sure.
So
Yeah,
the
I meant pulmonary hypertension.
yeah, pulmonary hypertension, I think, is a reasonable consideration, right? In terms of, I think that if pH inhibitors do increase pulmonary pressure, right, as you would expect from what we discussed, right? So the other groups that I think you warrant some consideration of potential, that I might not choose VADA as first line. Unfortunately, patients with active malignancy are a problem for everything, right? ESA, of course, has been studied in those patients, and we know they are harmful. HIF-PHI have not been studied in those patients, but we have reason to believe they might be harmful. Okay, so that's going to be a tough choice regardless. The other group is, well, the one obvious group is we shouldn't use HIF-PHI in people with advanced or severe liver disease, not because of adverse effects observed in the clinical trials, but honestly, it just hasn't been studied at all, right? There was no difference in liver events in the clinical trials. But the other group is PKD. Let me just say that PKD is a group that some folks, I think appropriately, might choose ESA over HIF-PHI. The last thing I know we need to get going is that your mention of retinopathy. When we first started working with these drugs 10 or 15 years ago, we were doing retinal exams before we used them. We had criteria regarding retinopathy. We were worried about VEGF. And frankly, every one of these drugs in development essentially showed at therapeutic doses no statistical difference in VEGF and no increased incidence of retinopathy, right? So that has become less of a concern.
And how about African Americans with APOL1? There is some literature that maybe hypoxia induces APOL1. We have seen also this in our studies.
Yeah. The data that I'm aware of in that regard really is thinking about progression of chronic kidney disease, right, and residual renal function. And I think that for the most part, when we talk about our dialysis patients, almost everybody that I shared with you in those studies, we presume residual renal function is not, certainly for the in-center hemodialysis patients. I think for your brand new incident PD patient, I frankly don't have concern about it, but I think it warrants, to your point, warrants consideration.
Thank you.
Go ahead, Val. Maybe last question, because we are at the top of the hour. Yeah, go ahead.
Hi, Jeff. Fantastic talk, as usual. I just wanted to ask you a few questions. So given the lack of specificity of those HIF-PHI, is there any data on how they affect CKD and BD, and particularly the skeleton?
That's a great question. And frankly, better one for Tamara, probably, than myself. I honestly, to be clear, I've not seen any clinical data whatsoever, right, with regard to effects on either anybody quantifying clinical events or skeletal events in any way, frankly, with the HIF-PHIs. So the answer is I think there is some overlap with theoretical overlap with MBD, but from a clinical perspective, I'm unaware of anything showing any outcome.
Okay, thank you.
Tamara?
Yeah,
Are
I
you-
don't have an answer either.
Yeah.
Maybe it's a question we should look into
Yeah, it's a good question,
if
David.
there are data. Yeah. Well, thank you very much, Jeff. This was really great. I think we
You
had the
bet.
highest number of attendees and the largest engagement. So thanks very much.
You
And have a
bet.
good
Thank you,
afternoon,
everybody.
Everyone.
Take care.